Mr. Speaker, today marks the 9th sectorial presentation as Minister of Health and Wellness. And as a proud...
It's the 10th.
10th? Yes. The 10th, I'm being corrected. Wow. 10th presentation as Minister of Health and Wellness. And as a proud member of this Andrew Holness-led administration, I want to begin, Mr. Speaker, by giving God thanks for his mercies and guidance and protection during this very challenging journey. I want to also recognize and express much appreciation to the various teams I've had to work with during this period, starting with the Most Honorable Dr. Andrew Holness, Prime Minister, and the Cabinet of Jamaica, the team at the Ministry of Health and Wellness, led by various numbers of permanent secretaries, currently Mr. Errol Green and CMO Bisesa Mackenzie, stakeholder partners, my West Central St. Catherine constituents who are in the gallery. I want to recognize them and thank them for their support. And of course, my family, represented here today by my two sons, Charles and Adam. I am very proud to have been given the opportunity to serve over these years in this capacity, Mr. Speaker. I am humbled, always reflecting, reviewing my actions when required, while focusing on what, in my judgment, would serve the greater good of the Jamaican people. Along the way, there have been many reviews and recalibrations that were needed, but I have never lost sight of working for the people of Jamaica. Health, Mr. Speaker, can be a very emotive, and we can understand why. Emotive pursuit, and we can understand why. When a child is sick, there is anxiety and fear. When someone dies, it can generate depression and anger. When someone has to wait for care that requires prompt attention, but which is neither life-threatening nor severe enough for an emergency room, it can generate feelings of hopelessness and helplessness. When an elective surgery has to be rescheduled for a loved one, there may be a view that the system has failed them. Mr. Speaker, I do not take these matters lightly. In fact, I've always believed that no matter how much we achieve, there is always room for improvement. As Minister, alongside doctors, nurses, and the entire public health team, I therefore remain committed to continuously enhancing our service delivery and ensuring that we respond with empathy to those affected, especially when concerns or complaints are raised. Mr. Speaker, let me say up front, before I get into the details, that we are not yet where we want to be in public health, but we are certainly far better off today than we were 9+ years ago when this government comes. I intend to show why this is so today, as I ask the Jamaican people to stay the course so that this government can continue to build on our health systems for the benefit of the people of Jamaica. Mr. Speaker, over the last year, the public health system saw some 3 million, and I'm rounding the numbers now, 3 million visits, 1.9 to health centers and 1.15 to hospitals. It is very important to note in these numbers and the trends in the preceding years that over the past 5 years, more Jamaicans are visiting health centers and less Jamaicans are going to hospitals. This, Mr. Speaker, is a very important policy success. There are approximately 300,000 more visits to health centers and 250,000 less visits to hospitals in 2024 when compared to 5 years ago. This is so because our health centers have benefited significantly from improvements in infrastructure, added services, and better service delivery. This government has invested in community health care, and the people are getting the benefits of this improved service. I would like to demonstrate the why and the how this is so. To provide context, however, in 2024, there were some 63,000 surgeries performed in public health. 10 million lab tests, 703,000 diagnostic imaging tests, and some 511,000 visits to accident and emergency. Together, more than 2,400 doctors, some 5,500 nurses, 2,000 plus community health aides, more than 1,900 paramedical and allied health workers, as well as our administrators and contractors of services, catering, cleaning, portering, security, and otherwise, have performed their duty to the over 3 million visits to our health system. I want to pause, and I would ask the House to join me in thanking them and recognizing them for their efforts over the past year, acting on behalf of the Jamaican people. Mr. Speaker, the opposition would like the Jamaican people to believe that they finally, in 2025, have the answers to the challenges in public health. They frame their conversation in isolation of the context of where we're coming from, where we are now after 9+ years as government, and the vision and the plans we have for the future, as reflected in our 10-year strategic plan tabled in 2018. They also conveniently ignore current plans being implemented to improve the system after decades of neglect. Mr. Speaker, to my mind, it is a self-serving, at times deceptive, and I may be even so extreme as to say dishonest narrative. I urge us to cast our minds back to 2015 and just look at how they left the health system. Simply put, it was broken, Mr. Speaker. The news headlines during that year, 2015, tells the tales, Mr. Speaker. In fact, I don't recall at any point in time during this administration any health worker, any surgeon making the statement that surgeons had to don garbage bags in order to perform surgeries in the public health system. Well, you know, Mr. Speaker, having cast our minds back to 2015 as a base year for an objective comparison, I would also say that we should not go by media headlines alone. In fact, I'm prepared to say that we have all been subject to media headlines and sometimes feel that we are victims of media headlines because oftentimes it is more anecdotal than capturing the context of a particular circumstance. So let us examine the facts to determine how much better off we are when compared to 2015. Back in 2016-17, the budget for capital projects in health was 1.88 billion, while the staffing budget was 31.12 billion. This year, 25-26, health's budget for capital projects is up to 10.18 billion, a mere five-fold increase from 2015 and from the 6.9 billion in the last financial year. The staffing budget stands at 93.77 billion, up from 33 billion in 2016-2017. Simply put, under this government's tenure, there have been more hospitals and health center build-outs, more posts for healthcare workers, and more compensation for our workers, Mr. Speaker. Mr. Speaker, there is no question that this administration is making a sincere and tangible attempt to improve our health services, and certainly better than any attempt before 2015. Let me say again, there are still challenges, but we are better off today than we were back in 2015. Mr. Speaker, we must stay the course in order to continue with these improvements. Another example of how and why the Jamaican people are better off from government health services since 2015 is through the expanded role of the National Health Fund. One significant example of the NHF's provision of coverage for only 2 cancers in 2015, breast cancer and prostate cancer. Today, the NHF provides coverage for 5 cancers: lung cancer, colorectal cancer, and multiple myeloma, in addition to breast cancer and prostate cancer. Further, Mr. Speaker, the agency has also expanded its coverage from 16 conditions in 2015-2016 to 24 conditions in 2024, including attention deficit hyperactive disorder, lupus, Parkinson's disease, and thyroid disease. These were conditions that were never covered under the National Health Fund up to 2015. To make the point even more, Mr. Speaker, since 2015, in 2015, the NHF prescribed just under 1 million prescriptions. Last year, the NHF wrote 3 million prescriptions providing free or subsidized drugs to Jamaicans. The Jamaican people are in fact better off today, Mr. Speaker, and this is why we urge them to stay the course. Yes. Mr. Speaker, I want to spend a little time responding to the opposition leader based on his comments during the budget presentation, because he did spend a lot of time on health, and he made a number of comments and criticisms. And, you know, in our democracy, we're all entitled to our opinion, but we're not all entitled to our own facts. Opinions are opinions and facts are facts. And I think it's important to address some of the issues raised. The leader of the opposition says he wants to improve primary care with a focus on building out health centers. That is a good thought, but has he made any effort to see what we have been doing? Mr. Speaker, last year we published this document, Mr. Speaker, the Primary Healthcare Reform for Jamaica 2021-2030. And this document, Mr. Speaker, outlines very clearly this 10-year development plan for primary health care, the clear shift towards screening and prevention, and we are in fact doing it as we speak. We are adding more services at the community or primary level, including adolescent health, elderly health, rehabilitative and palliative care, as well as ophthalmological and audiometric screening, together with dentistry, diabetic retinopathy, and lab services, among others. In other words, Mr. Speaker, what the leader of the opposition was calling for or promising to do, this Jamaica Labour Party government is already doing. And they say imitation is the best form of flattery. We have no problem with it. What we would say, though, is credit us with doing what we're doing, even if you want to do it also, should you have the time and the space so to do. Another example, Mr. Speaker, of the commitment in keeping with responding to the opposition leader to developing primary health care is under the Health System Strengthening Program. This is a program that is financed by the IDB, by the EU, and by the government of Jamaica. Under this program, 13 health centers and hospitals are being equipped with digitized patient records, modern diagnostic machinery, and these facilities will see new services and expanded staff for the communities they serve. And I want to just outline, for the benefit of all, what this government is doing as it relates to health centers. Maypen, under this program, and this is just one of several programs, Maypen West Health, $300 million. Maypen East, $748 million to spend. St. Anne's Bay Health Center, $309 million. Ocherios Health Center, $759 million. Brownstown Health Center, $765 million. Moko Health Center, $139 million. Greater Portmore, $513 million. Old Harbour, $681 million, and St. Jago Park, $516 million. These figures, Mr. Speaker, represent commitment to primary health care. Under the Operation Refresh, we have completed some 13 health centers to the tune of more than $100 million. The works have included the addition of AC units, waiting area upgrades, doctors' offices, bathrooms, and the addition of running water as well as kitchenettes. In fact, Mr. Speaker, a look back at the last 5 years and the expenditure on primary health care, health centers, equipment, and personnel shows that some $3.88 billion has been spent across the 4 regional health authorities to upgrade primary health care facilities. And it's all there. $99 million for Westmoreland, 87 million for Trelawney, 205 million for St. James, 49 million for Hanover, and I could go on and on. Every single parish have gotten an allocation for health centers as part of our primary reform upgrades. In addition to the addition of services and improved infrastructure, we are making available more points of care for the people of Jamaica, even as we adopt the life stage approach, which accounts for, among other things, biological, behavioral, and social factors that influence a person's health and well-being from birth to old age. Mr. Speaker, the opposition tends to like to call for audits because we're building out so much. And we have no issues with audits. It's a process, it's part of what our democracy allows for, and we welcome audits at any time. There's a difference though, in a sense we're at a disadvantage because when they were there, we couldn't call for any audits because they weren't building anything.
No money was there.
They weren't building anything. This government over the last 9 years has put more money into infrastructure for health centers than any other government before, Mr. Speaker. We have also added staff. Since 2016, we have established some 1,900 posts for medical officers, a 30% increase in doctors at the primary level, Mr. Speaker, from 338 to 432 in 2025. 1,495 posts for registered nurses and 97 new posts for midwives. Over 1,000 for community health aides, and move the health inspector cadre from 460 to 862, as well as 70 additional permanent posts for vector control workers. Mr. Speaker, we are putting people into healthcare to provide better service for the people of Jamaica. The opposition leader wants us to give more time to screening for NCDs. That was the other point he made. But we're already doing it, Mr. Speaker. When I mentioned that we were doing the Know Your Numbers, he sort of shrugged it off as being not consequential. Well, I'm here to tell him that under the Know Your Numbers program, we did some 289,000 tests over the last year and a half. Screening for blood pressure, blood glucose, cholesterol, body mass index. And in fact, it's a valuable program because between 25 and 30% of persons screened had abnormal readings. So his call for screening is a good one, the difference being that we are already doing it. And we are encouraged by that call and will continue to expand. In fact, this year we will continue the rollout of screening island-wide, also as part of the primary healthcare reform, which champions routine screening and delivery of health education messages according to the life stage approach. We will integrate the Know Your Numbers, therefore, into the health center, thereby enabling the increase in the health literacy of the population for better decision making. In other words, Mr. Speaker, the government is prioritizing screening and will continue to expand under our new life stage approach. They are saying it, we are saying it. The difference is we are doing it and will continue to do so, Mr. Speaker. The opposition also, the opposition leader that is, said he wants to put an MRI machine in every parish hospital. Now, this is interesting because in 2015, the last year before they demitted office, there were no MRI machines in the public health system, only 2 CT scans, and no mammogram machines or digital X-ray units. Compare that to today. Today, the public health system, including the University Hospital of the West Indies, boasts 3 MRI machines, 5 CT scans, 3 mammogram machines, 20 digital X-ray units, and 11 portable digital X-ray units, more than any time before, Mr. Speaker. The question is, do we need more? Of course we need more. We do need more, and so we will agree on that. But more is on its way, in that we have the leasing program, which is about to be completed through the procurement process, which will see another 10 CT machines and 6 MRI units being added to the fleet of important diagnostic as part of a leasing arrangement. I want to address, Mr. Speaker, the issue of Cornwall Regional, where the opposition likes to reference as a sign of failure on the part of this government. Firstly, the biggest lesson from the Cornwall regional experience is the consequences of maintenance neglect of our health infrastructure. And let me just say, without any fear of contradiction, that the opposition is not an innocent bystander in this regard, as they would like to now posture. Between 2004 and 2016, chronic inefficiencies plagued the hospital air conditioning system, stemming from poor and inadequate maintenance, poor planning, and inadequate evaluation of the challenge. By 2009, air quality issues emerged across multiple floors, which worsened by 2015, at which point the staff were being affected by chemical odors and contaminants. Mr. Speaker, it is they, for the most part, who neglected the problem from then, which led to the serious deterioration and which we now have to fix this government. We have to respond to the crisis, we had to, of collapse by building out a set of infrastructure to serve patients while shutting down the main building for repairs, all this while suspending renovation activities for 3 years to deal with the COVID-19 pandemic. That's the context that they conveniently avoid. You know, Mr. Speaker, Cornwall Regional is like, just to kind of simplify it, it's like a jumbo jet flying over the Atlantic Ocean with 450 souls on board, because that was the occupancy level at the time. And there are some difficulties developed by the engine. And if you follow the opposition, based on their criticism of time, they would try to fix the engine at 36,000 feet, which would likely lead to the death of everybody. In our case, Mr. Speaker, we had to land the plane, disembark, find alternatives for those who were in the institution, and then took our time to address the problem in Cornwall Regional, Mr. Speaker. Now, let me just state categorically that I regret, and this is sincere, I regret the inconvenience caused by the time it has taken to reopen the Cornwall Regional. I am indeed sorry that a solution could not have been found earlier, and I genuinely say this. I, however, reject any notion that this was either deliberate or based on anything untoward. All efforts were made to do the right thing, and today we are doing the right thing, Mr. Speaker. I also reject this mischief that this price tag is based on some cost overruns. Let me just outline. The government has so far spent more than 9.4 billion on Cornwall Regional Project, not the 24 billion. As a matter of fact, every time I hear opposition member reference Cornwall Regional, they move the figure from 23 to 26 to 27. So let me just say, up to now, up to this point, we have spent $9.4 billion, 620 million on professional services, 5.8 billion on works, 235 million on medical equipment, 2.2 billion on the operation of temporary facilities, which needed to be put in place to deal with the persons who are in the facility and subsequent treatment of others, and close to 524 million on support services. This involved, by the way, to date, this is important for the record, Mr. Speaker, this involved some 35 contractors, as I understand it, with a procurement process that at times involved 5 to 7 months to reach a decision. The much talked about 23 billion price tag is a projection. Yes, it's by us, it's a projection, but we haven't spent it as yet. And we are not there yet. The narrative, therefore, of criticizing cost overrun based on a $24 billion is not only an exaggeration, it is a dishonest description of the challenge that we face at Cornwall Regional and the approach that we have taken. Mr. Speaker, you know, Mr. Speaker, the opposition raised issues, and perhaps in their role, rightfully so, about value for money. And just to be clear, the call for an audit of Cornwall is redundant because the Auditor General is at Cornwall doing an audit, which we welcome and have no issues with. But context is important when we think about value for money. First of all, you had an old 50-plus-year-old building that was never maintained. That was poorly designed, as much as we accepted the gift from the Canadians, that had full capacity occupancy when it collapsed, and we had to therefore act within that context. That context meant not shutting down immediately and putting everybody out on the street, or people would have died. What that context meant is that we had to build a replacement around Cornwall, transition the services into that replacement, and while we were trying to address the problem, the rescoping was necessary because the building was far more sick than we had anticipated. What is bold about our approach is that this Andrew Holness government decided not to take a band-aid approach, but to fix the problem once and for all, Mr. Speaker. And in fact, they should be credited for it. But you know, Mr. Speaker,
no money.
It is said that children, or should I say, there's a old tale that says fools and children should not be shown unfinished work, because there is the potential of misunderstanding what the finished work will look like. I'm not accusing the opposition of the former, but they are acting like kindergarten children when it comes to trying to assess in a deep way what challenges we face with such a life-saving institution and why it was necessary to take the action that needed to be taken. The idea, Mr. Speaker, that the services of Cornwall are not continued is also not true, and an insult to the men and women who have worked hard to preserve health and save many lives each day. Over the 6 years of Cornwall Regional's main building closure, the hospital has actually performed creditably, because the hospital is not the building, it's more the people who provide the service. Absolutely. Mr. Speaker, in 2024, outpatients saw 86,000 visits, rounding off the figures, accident and emergency 40,000, inpatient 13,000, surgeries 3,101, lab tests 1.7 million, oncology 11,000 plus chemotherapy treatment, 612 patients receiving radiotherapy treatment on the Linac machine, and some 10,000 treatment for dialysis. Wow. Cornwall Regional, Mr. Speaker, at the end of it is a case study on how not to maintain a government infrastructure, and we must all learn from it. In the meantime, I am happy to announce that we are seeing the end of this long journey to restoring Cornwall. The new offerings at Cornwall Regional will have 11 new operating theaters, new CT and MRI additional diagnostic services, an A&E department that is close to twice the size of the original, new maternity suite, new and expanded dietary serving Cornwall Regional and Western Child and Adolescent, a new nursery, new intensive care unit, and all the other amenities which will be totally new. You know, Mr. Speaker, we have consultants on this project that are not based in Jamaica. Back to the value for money issue. And when you compare what it would cost to build a 40,000 square foot space, as Cornwall is, in the United States of America, I am told that it would cost anywhere between $700 and $1,200 US per square foot just for the building. Cornwall, that would equate to up to about 45 billion Jamaican dollars for a similar establishment. Cornwall Regional, if the projections follow through, which we expect it to, will be built and equipped for less than half that amount. And from that perspective, Mr. Speaker, I think we are getting value for money, and I believe the people of Western Jamaica and Jamaica will be better off for the decision taken by this government. We need to avoid a second Cornwall, however, Mr. Speaker. As a government, we are therefore now focusing on the Kingston Public Hospital, the facility which opened its doors in 1776 and which currently boasts 484 beds, has been plagued by challenges due to the age of the plant and poor maintenance. I'm happy to announce that we have now identified lands for lease to purchase and have commenced plans for a new KPH. Mr. Speaker, a land use survey report was prepared on the properties around KPH, inclusive of the 35 parcels identified, and the National Land Agency is coordinating the compulsory acquisition of the required lands. More will be said about this, Mr. Speaker, in the future, but we have to now focus on KPH while we learn the lessons from the Cornwall Regional Hospital. That's the sensible approach, and as a government, we intend to do just that. Mr. Speaker, significant renovations are taking place at other health facilities. We have spoken about the University Hospital of the West Indies. We are in the final stages of procurement, 6-story building, 120,000 square foot medical facility, 40 medical and surgical beds, improvement in outpatient, lecture rooms, conference rooms. Remember now, UHWI is very important to training our health workers. And so we have to invest there and expect an announcement soon and a breaking of ground, which the opposition doesn't like, by the way. They don't see groundbreaking as progress. And we will have a groundbreaking because we need to encourage and build confidence in the system that things are happening and things are happening in public health. But together with the Western Child and Adolescent Hospital, which is 220 beds, final stages of completion, we expect that to be completed sometime this year. These developments should see across the country more than 450 additional beds being added to the cadre of beds in our country. In addition to that, we have already added some 338 beds during the COVID period. So as a government, over this period, we would have added close to and are building out some 830 beds to add almost 20% additional bed capacity to our fleet of beds in public health. Mr. Speaker, a critical pivot point to improving health services is filling the gaps that exist for healthcare workers. We have long had shortages of specialist nurses, specialist doctors, and other critical support staff like radiologists, biomedical engineers. Our last count suggests a shortage, for example, of radiologists by more than 50%, and a shortage of some 1,388 of specialist nurses of various areas. Two factors contribute to this: the increasing mobility of our skilled labor force with the increasingly attractive offers to incentivize economic migration. The fact is, countries are competing for healthcare workers. Jamaica is a soft target because we produce good healthcare workers and we're close to the main developed markets of the US and Canada and the UK in some instances. Secondly, the government's health reform strategies, which are seeing more posts and greater demand for these specialized skill sets locally. So we are actually creating more posts. I just commented on that. So we need more people in order to serve the profile and the demand of the population. In other words, Mr. Speaker, we have to fix the HR issue as we build out the infrastructure to give the people of Jamaica more services and services that they require. I'll give you an example. I won't go through all of them for time. Psychiatric nursing, we have 140 currently employed. We need 360. We have a 220 gap. Pediatric nurses, 69 employed. We need 283, 214 gap. Oncology or cancer care, 21. 130 required, 110 gap. Nephrology, 59, 130 required, 71 gap. Just an example of the shortages that we face. Mr. Speaker, we have to be more aggressive in our push to right-size our HR policy for better service delivery. How are we doing this? Firstly, if Jamaicans are qualified and available, we will pursue this option as a priority. We also have to help locals who are willing and able to qualify for these posts. And this government is doing just that. That is why we introduced the Barrowin Scholarship, which last year awarded 600 scholarship places. 536 were taken up, Mr. Speaker. And as a result, these persons are actually studying various areas of medical or healthcare with the intention of coming back into the public health system because it's a development scholarship. I am happy to announce that this week we will advertise another $500 million for scholarships in the print media and on the website of the Ministry of Health and Wellness for new applicants for the new year. We did say it was for 5 years, $500 million a year. The next application will be this week. Mr. Speaker, we are, however, in keeping with the development nature of this scholarship, we're going to be targeting certain areas. This may not be exclusively so, but primarily so. So this tranche of advertising will look to encouraging biomedical engineers, medical physics, speech therapy, third and fourth year nursing and midwifery, occupational therapy, radiation therapy, and dental nurse therapy, and nursing educators. Mr. Speaker, we have to ensure that we give, and are ensuring that we give, more Jamaicans priority at all times. But history has shown that there is a limit to this due to the external and local factors. And so we have to continue to expand our outreach to meet demands of our healthcare needs. And this is not new. We are committed, for example, to continuing our Cuban partnership, as these arrangements have been of significant benefit over the years. And this propaganda that the opposition and others have been pushing, that somehow we're sending Cubans home, I want to just say very clearly that we value the partnership with Cuba. We value their contribution. Currently, we have 88 Cuban doctors and 199 nurses here. And I want to just recognize the initiative and their efforts. And hopefully we'll continue to build on that. The future of HR in health will require more collaboration, however, using technology and friendships to fill the gaps that have been and are being created from a highly mobile labor force. We have to look wider, think deeper, and adjust our traditional thinking around who and how to get more skills in healthcare. We have started through exploring long-term relationships in training and clinical exchanges with India, the Philippines, and Nigeria. In the first instance, these countries were targeted, Mr. Speaker, based on friendships, existing friendships, compatibility with language, training modules and technology availability, and past experiences with these nationals as healthcare workers in Jamaica. Earlier this year, you would have heard that I visited both the Philippines and India. We had excellent discussions, and there's a follow-on in terms of trying to materialize or actualize these relationships for the benefit of training. Where training is not sufficient and we have gaps and our patients or Jamaicans need help, and we can establish a clinical exchange where doctors come here, nurses come here to fill some of the gaps, Mr. Speaker, we're going to have to do the same thing just as we do with the Cubans. More will be said on that in the future. Mr. Speaker, I want to quickly turn to what I consider to be challenges that we have to confront. I address them as pain points in public health, and to suggest approaches that we will over the next year or two try to address in order to drive greater efficiencies. The first one is operating theaters. Now, too often we have downtime in our operating theaters, which leads to surgeries being cancelled. We're also challenged by the high trauma nature of our society. Bike accident, motor vehicle accidents, domestic violence, which, by the way, is coming down because crime is now moving down faster than any other point under this government, which, by the way, is a positive impact on the healthcare system. Very positive impact. And so the government must be recognized for that. At any point in time, we have between 25 and 20% of our operating theaters down. We have about 73 in the country, public health system, including 17 at the University of the West Indies. I've been talking to the surgeons, talking to the administrators to find a solution. As a result, I've asked the regional health authorities to do the following. Firstly, to appoint an operating theatre manager at each hospital whose responsibility it will be to ensure the best practice protocols are followed for scheduled maintenance and usage. Some hospitals have operating theatre managers, some do not. We're going to standardize it across the board. Secondly, develop and implement a revised policy on supplier servicing and inventory of parts to ensure quick turnaround for repairs. And that's important because oftentimes you have the money to pay for repairs, but the supplier tells you you have to wait 2 months or 3 months. which to my mind is unacceptable in an essential service. And so where suppliers cannot guarantee parts within a certain time, then to my mind, we have to find alternatives. And regional teams have been mandated to that. A third and major area of concern is air quality and maintaining efficient ventilation systems in our operating theatres. I have asked that all operating theatres have a backup ventilation system from when the main system goes down, either unexpectedly or for maintenance. Again, this is an inconsistent feature throughout the country. The University Hospital of the West Indies, for example, has 17 operating theatres. They rarely go down because they have a backup system. In the past, some surgeons have been against the smaller systems because of challenges with air quality. But the technology has provided for temporary backup systems, and we want to ensure that we install in all operating theatres across the country to ensure greater consistency. I'm also happy to announce, Mr. Speaker, that we see the need for additional operating theatre capacity. As a result, we are building out, as we speak, and have built some already, and more to come over the next year or so, 27 new operating theatres to add to the capacity of operating theatres. That's a 37% increase in new operating theatres over the next 2 years. Cornwall Regional Hospital will have 11 new operating theatres. Spanish Town Hospital, which has 2, will have 5. St. Anne's Bay, 1 additional. Maypen, 1 additional. Western Child and Adolescent, 4. Shackleton, Noel Homes, National Chess, and Lionel Town, and Linstead Hospitals will get 1 or 1 additional. That's 27 over the next year and a half, Mr. Speaker. We will, as a government, improve our existing maintenance arrangements for operating theatres and add significant inventory, Mr. Speaker. That's why we need to stay the course. And that's why we ask the Jamaican people. We have a plan, and we're living by that plan. The other area, Mr. Speaker, is triage and A&E. Many Jamaicans still do not understand that A&E does not operate on a first-come, first-served basis. So that those cases that are not urgent are likely to be told to wait for many hours before seeing a doctor following an initial assessment. They would understandably become disgruntled because of the long wait. And so the real challenge is, how do we identify quickly that 25–30% of persons who really don't have an emergency? And what do we do with them to get them treated or tended to as quickly as possible to avoid the frustration with wait? You know, some years ago we started this program where 29 health centers are offering extended hours from 4 p.m., in some instances up to 10 p.m. As part of the expansion of this initiative, in keeping with trying to manage A&E and the long waits, we are codenaming Extended Care, which is a similar program that will add another 25% more health centers, particularly those closest to hospitals, but some in critical town centers, where we will standardize the opening hours from 4 to 10 p.m. and also are looking at the possibility of offering pharmacy services within those contexts. So in other words, if you live close to one of these health centers, you don't need to go to A&E because you have an emergency or a perceived emergency. You can go to a health center which will be open up until 10 p.m. Now, it's important to note, Mr. Speaker, that in 2015, of the 300 or so primary healthcare facilities, only 60 of these were offering doctors' consultation and curative visits 5 days a week. Only 60 of the 300. We are now intending on doubling that capacity, adding another 67 health centers that will offer a doctor within those health centers 5 full days a week. I go out a lot in the countryside, and oftentimes when I go, particularly deep rural, I get the comments from the health center operators or the people in particular, who say, listen man, I need a doctor. Can you put a doctor in this health center? And it's a genuine call. And the reality is, if we had a doctor in those health centers, persons would not want to go to the town centers. And in fact, We have expanded that during the 9-year period. What we intend to do is to double that, which will again contribute to more people going to health centers and less people turning up at hospital because they think they have no choice. So we'll be working on that, Mr. Speaker. I want to touch on food handlers permit. A lot of people may not know that the Ministry of Health manages food handlers permits, and approximately 300,000 persons apply. Until I'm finished. That's not how we say it.
Mr. Speaker, in keeping with the principles of the standing order as we have indicated, I beg to move that the member's time be extended by 15 minutes to allow him to complete his presentation. May it please you, Mr. Speaker.
The request is on the floor that the presenter time be extended by 15 minutes. Those in favor? Those against, the ayes have it. You may continue.
I want to thank the House Leader, but I think it was Bob Marley who said so much things to say right now. So much things to say. I'll try. I want to look at food handlers permit. Food handlers permit. Some 300,000 Jamaicans each year apply for food handlers permits. And oftentimes they have to wait 3, 4, 5, 6 months for a permit that lasts 12 months. So as soon as they get it, they have to reapply. The process is cumbersome, it's bureaucratic, and it does create challenges for people who are doing business and require the food handlers permit. I've met with the Environmental Health Division, and we are overhauling the policy around the National Food Handlers Permit and Training Certification Program. This will involve extending the term for a food handler's permit renewal from 1 year to 2 years. So when you get it, it lasts for 2 years. Introduce convenient bill payment service option effective January 1, 2026. This idea of going to a place that is in a particular part of the parish, as opposed to going to a Paymaster or a Bills Express or the bank or somewhere, is no longer relevant. Times have changed, and so we're going to be changing that. Implement a bimodal modular training format to reduce certification processing time for 3 weeks, from 3 weeks to 2 weeks. Introduce new technology to facilitate faster and more efficient processing to eliminate delays and backlog, and increase the cadre of professionally trained food handlers to reduce the risk of outbreaks linked to improper food handling. And finally, increase application access points, reducing wait time and enhancing delivery. Madam Speaker, public health should ensure that food safety is priority, but we should not be a bureaucratic nightmare for business people who want to do their business. So we have to modernize this process, and we will. I want to turn to another point, which is pharmaceutical approvals. Last year, we saw some 2,518 applications for approvals at the Standards and Regulations Division. 10 years ago, we were averaging some 1,700. So there have been a 46% increase in applications by importers or pharmaceutical distributors for permits. A lot of times, and this is a big area of complaint by the importers and the pharmaceutical distributors, a lot of times I'm told by the team that the issue is the incomplete dossiers. In other words, the forms that you fill out and the supporting documents. Because the system is so antiquated, Mr. Speaker, those applications have to await a response, which sometimes takes a long time. And so it creates a bottleneck, and it creates and affects the smooth flow of business. And indeed, patient care, because we do need the drugs to assist our patients. We will then therefore move over the next year to do the following policy changes based on discussion with the team internally and my own discussion with some of the stakeholders externally. We're going to establish a protocol for greater dependence on what we call the reliance system for drug approvals in collaboration with the US, UK, and European standards. What that means is that if a drug is approved by the US or the UK regulatory agencies or the European regulatory agencies, then it will be fast-tracked in terms of the approvals here in Jamaica. In a sense, we are relying on their interrogation of that process, and we'll establish relationships in order to do that and make whatever necessary adjustment in interrogation that we need to make, but we'll place some reliance on that. We will also move to digitize the application process so that applicants will not need to wait for a response to determine incomplete nature of their application, as this will be flagged on the online application process while filling out the form. So some 80% of delays are linked to incomplete dossiers. The online application would not be accepted if you do not tick all the boxes to demonstrate that you have completed that process. And finally, in addition, we will establish an express window for local manufacturers who apply for approvals once they are manufacturing locally for the local and export market. I believe that health needs to aid export and local manufacturing. And so we will give priority to those local manufacturers. And this we hope to begin working on and hopefully completing over the next 12 months. Mr. Speaker, I want to turn to this important area of older persons in our population. The older population, 60 years and older, in Jamaica is the fastest growing age group, increasing at approximately 1.9% annually from 264,000, rounding the numbers, to 360,000 between 2001 projected to 2030. The dependent older population, 65 years and older, was estimated at 199,000 in 2001, expected to increase to 321,000 in 2030. The working age will reach its maximum based on these projections in 2025 at about 66.5% of the total population. And if we extend that up to 2058, these are projections that economists make, forecasting projections. The older population is predicted to be larger than the young, with a rate of increase faster than decline. Simply put, we are having an aging population, and we're going to have people with needs within that cohort more than we have today. Health has to respond to that, because what we're experiencing, Mr. Speaker, yes, including in this house, all of us, we're experiencing demographic transition, and public health has to be prepared to respond. The shift underscores the need to prepare for aging population, adopting societal structures including the workforce, health systems to address this evolving demographic landscape. And so from health's perspective, we are looking to the future. What do? We're preparing the health program for older persons plan, which seeks to maximize the period in which older persons maintain good health, wellness, and functional independence through the promotion of healthy aging through this life course approach. Building the capacity of at least 90% of healthcare practitioners in primary care to identify and manage healthcare needs in older adults, and to provide allied health and rehabilitative services to older persons with complex health and disabilities needs. To this end, Mr. Speaker, the primary healthcare system will become even more important, because more often than not, our older population will reside in their community and want to access quick care. And so under the primary healthcare model, we are rolling out training of health providers this year, so that the next 2 years we can establish basic screening for functional capacity, as well as a core of other services, some of which are outlined in the presentation, which I won't touch on at this point. I want to mention, though, Mr. Speaker, that we are expanding our family health programs to include older persons' health. While we do that, we're also turning our attention to women's health to address some specific challenges faced by our women. We have to look after our women. Yes. Right, men? I don't hear anybody say anything. Okay, thank you very much. We have to look after our women. I'm not going to comment on that. You're not commenting on that? Okay. Mr. Speaker, the perimenopausal period is one of those issues that affects the well-being and productivity of women. Menopause, we know, Mr. Speaker, is neither, yes we know from the science, is neither, according to men, because they have problems too. And they have problems too. We all will, it's a natural course of life. Menopause, we know, is neither a disease nor a disorder. Let me make that clear. However, it impacts the state of mind and the overall wellness of so many of our women, some of whom begin to experience symptoms as early as in their 30s. This is what the research says. In fact, a study by the British Menopausal Society notes that more than 80% of women will be menopausal by age 54, with up to 80 to 90% of women having symptoms, 25% of which will be described as severe or debilitating. There's also growing evidence that there should be a clinical response to this personal life stage experience. I've therefore asked a team headed by the Most Honorable Denise Eldemaya Shearer, who is an expert in that field, to explore and establish a standard clinical response for this life stage. It is time to recognize, Mr. Speaker, that our women experiencing these symptoms should not be experiencing it on their own. They deserve support, particularly in the context of an older population for the future. Now, but women are not the only ones at a particular life stage that have this issue. Older men are also an important focus within the ministry's care delivery framework. As men age, they undergo hormonal changes too, particularly a gradual decline in testosterone levels, which, although distinct from the hormonal transition experienced by women, can nonetheless lead to a range of physical, sexual, psychological health challenges. These may include fatigue, decreased libido, mood changes, and reduced muscle mass. Recognizing and addressing these issues is essential to promoting the well-being and quality of life of older men. Fitz the man
talking about you. Long time.
I think
that happened a long time.
You know, Mr. Speaker, one of the reasons why we can talk and laugh about it is because all of us will get there. But from my perspective as health,
I get there long ago.
Some of us reach and pass.
Some of us reach and pass. Okay. So, Mr. Speaker, seriously, as such, the specific health needs will also form part of the ministry's overall strategy to offer comprehensive care for the aging population through the adoption of the life stage approach. The point is that this government, this Andrew Holness-led government, is government for the last 9 years. We've thought about everything. And we have a plan to deal with every reality. And that's a good thing for Jamaica. That's a good thing for the people of Jamaica. And guess what? We're not just thinking about us, we're thinking about you too. Right, Fitz? Everybody. Mr. Speaker, I want to quickly touch on mental illness because it has been a source of stigma and misunderstanding. We have, however, begun to chip away at entrenched stigma, deepening public understanding and confronting the culture of silence that too often surrounds mental health. A number of things are being done. I'll skip some of it that is listed here, but we are getting more responses. And I want to just quickly outline how the data is showing that. The number of people seeking help through our mental health clinics has increased from 107,000 visits in 2015 to 190,000 in 2021. The mental health and suicide prevention helpline saw a substantial rise in usage, as mentioned earlier. And the Do Your Share Mental Wellness campaign has in the past 18 months donated wellness benches across the country. And we are also pursuing this wellness check initiative. There are a range of things that we are doing. Now, what are we going to be confronting over the next year to try to address the challenge of expanded mental health challenges, particularly in the post-COVID era? Fill vacant psychiatric posts to improve service coverage. You would have heard that we have created more posts. Expand community mental health service with the addition of mental health officers and psychiatric nursing aides. Establish psychiatric emergency and maintenance teams in selected urban centers to improve response time during crises. and update a national mental health policy to shape the sector's future. This is so important, Mr. Speaker, and we will speak more on this over time. I want to quickly touch on maternal health, because we have had challenges there, and I'm happy to report that we are making or showing improvements in addressing those challenges. We continue to advance a coordinated and strategic response to reduce preventable maternal and neonatal deaths in Jamaica. Through strengthening governance, targeting investment, the maternal and neonatal health program has made significant progress. The Sustainable Development Goal sets us 70 maternal deaths to 100 live births. An upward trend in maternal mortality ratio for Jamaica over the past 2 decades has been a major concern, and we all should be concerned about that, where we had up to 213 deaths per 100 live births. Today, that trend over the last 3 years has come down to 133 deaths per 100,000 live births, which is an improvement, and the trend suggests that those improvements are continuing. More than 320 health centers, many of which have undergone recent renovation, offer maternal and child health services. There was a marked improvement in the proportion of women who sought antenatal care in the first trimester, reflecting early engagement and equitable access. In fact, we are really encouraged because the work that we have been doing at the primary level is showing now that in 2023, 45% of women received antenatal care in the first trimester compared to 22% in 2018. So the message is getting out, and it's leading to more lives being saved or secured. Recognizing the vulnerability of adolescents, Jamaica launched a dedicated teenager clinic at the Victoria Jubilee Hospital, the largest maternal hospital in the country and the English-speaking Caribbean. I want to also comment, and I'm skipping through in the interest of time, that we should all be proud, Mr. Speaker, to note that Jamaica has achieved the elimination of mother-to-child transmission of HIV and syphilis. This milestone, celebrated on May 7, 2024, along with Belize and the St. Vincent and Grenadines, make them the latest countries in the Americas to receive WHO certifications. Very, very important, and it's a credit to the work that the health team have been doing. Mr. Speaker, I want to project a little as I close in 10 minutes. As we build out our health infrastructure for the future needs of our population, we must continue to vision, forecast, and plan for the new and emerging opportunities to improve health service delivery. This is where leadership, Mr. Speaker, leadership requires serious thought, a futuristic examination of both the challenges we will face and the solutions for those challenges. Leadership is not about raising alarm about medical equipment based on what you see on Google. Leadership is about serious analysis and assessment. This is not a government by Google. This is a government by research. This is a government that is driven by science, and this is a government that is influenced by what is in the best interest of the Jamaican people. Mr. Speaker, here are a few trends we must watch and respond to. And I'm speaking about the third term and the importance of this government and all of us actually preparing ourselves. The future risk to our health will continue to be lifestyle diseases. A crude breakout of lifestyle disease show that 80% of our population who die each year are dying from NCDs. Broken out into general categories of diabetes, cerebrovascular disease, hypertensive disease, and ischemic heart disease. Those are the top 4 causes of death. It is also likely that we will continue to see stagnant or lower birth rates, which means aging population, which I addressed earlier. We'll also likely see greater outward and inward migration and a need for greater collaboration between friendly bilateral and multilateral partners for a more cohesive social and economic development. The truth is, if our population decline because of less than adequate replacement value in terms of birth rates, we're going to have issues in terms of labor force, as we are having now. We're going to have a lot of issues, socioeconomic issues, which I won't go into today, but I'm addressing now the health perspective. What is the public health response to these likely developments? There are many, but I want to focus on two quick ones. The 4 major causes of premature mortality and early onset of illness require a combination of prevention practices, screening, and treatment. And that's where I agree with the leader of the opposition in terms of primary health care and screening. Our current reforms to primary and secondary health care is an attempt at reducing the risk associated with these areas. But I think we need to do more to map the trajectory of these illnesses, Mr. Speaker, and determine the points of intervention that reduce the risk and support continued expansion in specialized monitoring and care. Mr. Speaker, I've asked a team headed by Professor Trevor Ferguson, chair of the NCD Commission, to establish subcommittees within this task force for the development of centers of excellence around these 4 key disease risks, which are the main cause of death in Jamaica. The committee will, among other things, look at the epidemiological profiling and surveillance, primary prevention and health promotion, integrated and people-centered care models, and policy governance and multi-sectoral action. The terms of reference will include mapping the life course of vulnerable groups and determining a pathway to continuous research and treatment for these diseases. And I've asked for a report over the next 12 months, which hopefully will then guide new policies and new programs to address what the future projections look like. Secondly, Mr. Speaker, is artificial intelligence. How can we discuss health and indeed anything without recognizing the trends that are taking place in artificial intelligence, technology? Mr. Speaker, this is one of the most important forward-thinking thrusts to secure the future of health service delivery. And we have come up, the team and I, with a phrase that we would like to capture this work under called artificial intelligence, technology enhanced care for health, or AI tech for short. We have to prepare ourselves for the changes in medical sciences and technology linked to treatment and care to make health screening and treatment more accessible and outcomes more predictable. And this is where AI tech comes in. So artificial intelligence, for those who may want a refresher, is the process of using technology-driven data to assess, analyze, predict, and influence outcomes. In healthcare, easier and faster screening, more minimal invasive treatment procedures, remote monitoring, and support for the chronically ill. So this is how it connects. If you have an aging population, and many older persons don't want to live with their children. They prefer to live in their own circumstances, their own homes. The children are going to be worried that they are on their own. The technology exists to provide constant monitoring and a response that could be remote. And the truth is, that is the future. That is where the process is going. We will not be left behind. This government will lead the artificial intelligence in an ethical way to support the trends in the future of our country. I'm announcing today, therefore, Mr. Speaker, an AI Tech Council of Experts, chaired by Dr. Ruben Pillay, Professor and Assistant Dean of the School of Medicine and Health Innovations at the University of Alabama in the US, to examine the trends and recommend new systems using AI technology to address the following areas. And these are the areas that we have come up with because we have spent some time preparing terms of reference, Mr. Speaker. Cross-border treatment support, including with radiology services. Lifestyle-linked medical profile predictability. In other words, you can actually be screened and a projection made as to what disease you're vulnerable for in the future. That's how advanced technology is. Community-based screening, we're doing that now, but you have to go to 4 different stations to get 10 more minutes and I'm finished. Thank you. 5 more, 5. Yeah, 5.
Member, you have 5 minutes to wrap up. Please.
Thank you, Mr. Speaker. lifestyle linked medical profile predictability, home care for the chronically ill or older population, ongoing monitoring and assessment, and any other new trends and practices ethically accepted in healthcare delivery. The AI Tech Council of Experts will conduct the necessary applied research and coordination to generate a report aligned to the country's 10-year strategic plan to integrate AI technology in our health services delivery. We have asked them to work for a year with a secretariat out of the Office of the Ministry of Health. It involves a number of persons on that committee, which includes University of the West Indies, the Ministry of Health and Wellness, and as I outlined, the chairman and a few others outside of Jamaica. So it'll be virtual meetings, and I'm hoping in a year we'll have a gathering, a one-day gathering in Jamaica, bring stakeholders in, discuss the findings, and hopefully integrate into policy over time. The future of healthcare, Mr. Speaker, is with AI tech, and this government will get it done, which is why we must stay the course. Mr. Speaker, after 9 years as Health Minister under this Andrew Holness-led administration, I'm proud of the team that has led this country through a series of crises while still building out our health infrastructure like no other administration before. Reviewing and reforming for better policies while preparing for the future challenges of healthcare. Just think of it. We managed the tail end of the Zika virus, then Chick V, 1 year of a dengue outbreak, then the dreaded COVID-19 pandemic, and the collapse of the long-neglected Cornwall Regional Hospital. And we are living to tell the tale. In all of this, we have remained steadfast, not panicking or surrendering by demonstrating strong and decisive leadership. While confronting these challenges, Mr. Speaker, we have embarked on the largest infrastructure upgrade of hospitals and health centers, and policies have clearly outlined the way forward for primary healthcare reform and secondary healthcare reform, adding more services than any other time, more doctors and more nurses. We have started to digitize our health system, a first in the Caribbean region for better patient care and management. We have fixed more health centers than any time before. We have promoted wellness as a lifestyle concept that encourages rest, relaxation, humor, and happiness. In all this, we have eased the burden of thousands and thousands of Jamaicans. This government has approached the health portfolio with a team in a way that's constructive and productive. Over the last year, Mr. Speaker, 4,274 Jamaicans benefited from Second Chance Smiles. 119,000 Jamaicans received prosthetic limbs for New Limb, New Life. 756,000 received free or subsidized drugs from the National Health Fund. 289,000 got free screening tests under Know Your Numbers. 1.9 million went to health centers and got served. 1.15 to hospitals, and 63,000 from life-saving surgeries. And we will continue to build out over the next term to bring some 450 more beds, 27 new operating theaters, more diagnostic equipment through leasing programs, more drugs from the NHF, more opportunities for training and development and benefits to the health team. I agree in conclusion, Mr. Speaker and colleagues, that we're not perfect, and there's always going to be a margin of error. It's a work in progress. We are not where we want to be, but we are making good progress, and Jamaicans are better and benefiting more today from public health services than any time before, and certainly up in 2015. So much done, so much more to do. Let's stay the course. We must stay the course. God bless Jamaica, land we love. Thank you, Mr. Speaker.
That was a sectorial presentation by the Minister of Health and Wellness, Dr. the Honorable Christopher Tufton. This broadcast was brought to you by the Ministry of Health and Wellness.
Yo, genius! Me just get the Burger King Double King combo. One original chicken sandwich plus a Whopper Junior with cheese. Well, a 2 sandwich.